Hi everyone, my name is Wei Mu. I am a neuroradiologist at UCSF, and today we will be discussing my approach to head trauma. I have no financial disclosures. Head trauma is an extremely common presentation to the emergency room, and CT is critical for evaluation. Blood is key to the evaluation of acute head trauma, and in this presentation, we will discuss hemorrhage as well as vessels. There are certain patterns of traumatic brain injury that we commonly see. One of these is that the inferior frontal and anterior and inferior temporal lobes are disproportionately affected. This is because in the acceleration and deceleration in the trauma, the brain moves separately from the skull and scrapes against the skull base. In this case, we can see that there are rounded as well as ill-defined foci of hyperdensity in the right frontal and temporal lobes. On the follow-up exam, we can see that these hemorrhages have increased in size. Another pattern we can see with traumatic brain injury is coup and contra-coup injury. The coup injury is a direct injury at the site of impact and is associated with fractures. The contra-coup injury occurs on the opposite side of the head and actually tends to lead to worse parenchymal injury. In this case, we can see that the coup injury is in the right frontal region, and the contra-coup with the associated intraparenchymal hematoma is on the opposite side in the left occipital region. We have been looking at examples of intraparenchymal hematomas. These tend to have round contours, are surrounded by hypodensity, which is vasogenic edema in the adjacent brain, and also have a tendency to increase in size on follow-up exams. Another form of parenchymal injury that we can see is called diffuse axonal injury, or DAI. In this case, we can see that there are tiny hemorrhages in the left frontal lobe at the gray-white junction, as well as in the right midbrain. On the follow-up MRI, we can see that there is indeed susceptibility associated with those hemorrhages, but there are also other foci of susceptibility that we did not see on the initial CT. DAI is caused by shear injury to the white matter tracts, and these will present as tiny hemorrhages at the gray-white junction or along other white matter tracts. This is often not seen on CT, and MRI with SWI is a gold standard for diagnosis. Now let's move on to extraaxial hemorrhages. In this case, we can see that there is a fracture along the left lateral temporal convexity with an associated lens-shaped or lentiform hematoma. On the CT angiogram, we can see that there is contrast within the middle meningeal artery, as well as other foci of contrast within this hematoma, consistent with active contrast extravasation. This is an example of an arterial epidural hematoma. Epidural hematomas can also be found in other locations. In this case, we can see that there is a fracture through the left frontal bone with an associated epidural hematoma. And in the same patient, some fractures along the left anterior temporal convexity with an associated epidural hematoma. These are venous epidural hematomas, and the example on the right is a named entity called the benign anterior temporal epidural hematoma. Epidural hematomas are lentiform in shape, do not cross sutures, and are associated with fractures. These are often venous, but can be arterial if they're along the course of the middle meningeal artery. In this case, we can see that there is an extraaxial hematoma along the entire right cerebral convexity. Also on the same patient, we can see that there are also blood products along the posterior falx as well as the right tentorium. These are examples of subdural hematomas. Subdural hematomas, unlike epidural hematomas, will cross sutures. These are also venous bleeds, so they tend to bleed slowly. And they're often mixed density, which is nonspecific. This can be seen with acute on chronic hematomas involving blood products that are clotting or settling, or with anticoagulation. It is also helpful to use other views to examine subdural hematomas. The coronal view is good to look for blood products along the tentorium and at the vertex. The sagittal view is particularly useful for the region around the foramen magnum and retroclival regions. In this example, we can clearly see that there are subdural hematomas in this area, but that would be very easy to miss on axial views. And now onto the last type of extraaxial hemorrhage. Here we can see that in the right temporal region, there are linear and ill-defined foci of blood products, as well as linear foci of blood products in the bilateral inferior frontal region. Similar findings are also seen on the coronal view in the bilateral inferior frontal regions, as well as the right temporal region. These are examples of subarachnoid hemorrhages. Subarachnoid hemorrhages are blood in the sulci and will have a curvilinear appearance. The post-traumatic subarachnoid hemorrhages are going to be peripheral and have a frontal and temporal predominance, whereas aneurysmal subarachnoid hemorrhages will be more central in the basal cisterns. They will also redistribute over time and end up as dependent blood products in the ventricles. Now that we have discussed the different types of hemorrhage, let's discuss the sequela of hemorrhages. In this case, we can see that there is blood extending into the bilateral frontal horns of the lateral ventricle, as well as the third ventricle. The ventricles are overall enlarged, with areas of periventricular hypodensity. This is an example of obstructive hydrocephalus with transependymal flow of CSF. In this case, we can see that there is a large parenchymal hematoma in the right cerebral hemisphere. If we draw a line down the middle, we can see that the brain on the right is herniating to the left. This is an example of subfalcing herniation or midline shift. On the same patient, we can see that compared to a normal patient, there is effacement of the fourth ventricle, as well as other extraaxial spaces in the posterior fossa. This is an example of downward cerebral herniation. In this case, we can see that there is a right temporal lobe intraparenchymal hematoma and associated medialization of the right uncus, or the medial aspect of the temporal lobe. This is probably a little bit easier to see on the coronal view, where we can see the uncus is indeed displaced medially compared to the normal side. This is an example of uncal herniation or medialization. And finally, we get to the vessels. Here we can see that there are some fractures along the expected course of the left internal carotid artery, or ICA. On the CT angiogram, we can see that the left ICA is markedly decreased in caliber compared to the right. More distally, there is a filling defect, which is consistent with a thrombus. So this is a case of left ICA dissection with a distal thrombus. In this case, we can see that there is a non-displaced fracture along the expected location of the left transverse sinus. On the CT venogram, we can see that there is a near occlusive thrombus in this region. And this is an example of dural venous sinus thrombosis in the setting of fracture. If there are any fractures that traverse the expected location of vessels, additional imaging is needed to evaluate for vessel injury. Once again, blood is key to the evaluation of acute head trauma. We looked at hemorrhages and what they can do, as well as vessels and how they can be injured. Here are my references. And thank you very much for your attention. Please feel free to email me with any questions.